Right, so good morning again. It's a pleasure to be here with you this morning to cover up this section as a continuation to our theme, our major theme, universal health coverage, ensuring that every man and woman, child, elderly, anyone, any Tanzanian is capable of getting their health services, be it curative or preventive services, where they are, whenever they need it, ensured quality, but at the same time, making sure that there are no barriers to accessing care. So this morning, we are pleased to take this forum with you to discuss about control, detection, and control of diseases, infectious and non-infectious diseases. And it's a pleasure to welcome distinguished panelists. Some, I'm informed, they'll be online. May I call on the speakers? Dr. Salim Slim, DPS, Minister of Health, Zanzibar. Round of applause to him. Dr. Salim Slim is a Director of Preventive Services, Ministry of Health, Revolutionary Government of Zanzibar. He is an experienced public health specialist with a number of years in field epidemiology and has actually significant contribution in the public health, particularly in the area of prevention, but also elimination of diseases. With his colleagues and his team, he's been able to spearhead and lead elimination of measles in Zanzibar. So I think this is a great achievement, as well as COVID a campaign, a vaccination, but also control of COVID, including also non-communicable diseases, particularly maternal health. So this is Dr. Slim Salim. Please, a round of applause to him. The second panelist is Lucia Pande, Secretary General, Red Cross. May I welcome Lucia Pande? Please, please take the podium. And I will give you the opportunity to introduce yourself. Please take the mic and give a word about yourself. Can you introduce yourself to the to the audience, please? Thank you.
Morning to you. I'm Dr. Hilary Ngude. I'm a medical doctor. I'm a public health specialist. I have over 15 years of experience in public health. I work as the Director of Health Services in Tanzania Red Cross, and I'm really happy to be here with you. Thank you.
Thank you very much. Thank you, Red Cross. A round of applause to him. We also have Dr. Charles Sagoe Moses, WR. He's also represented. Please take the podium. If I can call all the other panelists, please. Dr. Yenyu Kabede, Africa CDC. Africa CDC. Yenyu Kabede. I was informed that he will participate online. Do we have him online?
Yes, I'm online.
Dr. Yenyu, are you online? He's joined.
Yes. Can you hear me? Yes, I am online.
Thank you very much. Can I also call Professor Renz from Germany? So we have 5 panelists, and I will now introduce, because of time, I'll introduce them. And Those whom I do not have their bios will have to introduce themselves. So we have Dr. Enyu, who is online. Dr. Enyu is a highly experienced medical microbiologist and public health expert with 20 years of extensive clinical teaching, research, and laboratory management expertise. He currently serves as the head of Division of Laboratory Systems at Africa CDC. He leads initiatives to strengthen public health laboratories systems in Tanzania, including regional surveillance networks and biosafety standards. A round of applause to Dr. Enyu. Next, we have Professor Reins. Professor Reins comes all the way from Marburg, Germany. I hope you, when I say Marburg, you can recall something. That's the origin of the virus, Marburg City in Germany. So that's where Professor Reins comes from. He's the director of Institute of Laboratory Medicine at Philipps University of Marburg, Germany, and president of the German Society of Laboratory Medicine. He's a distinguished figure in non-communicable diseases with more than 360 original published papers in high impact factor journals, up to 85. So a round of applause. Thank you very much. And we have a representative of WR. Please take the mic and introduce yourself.
Yeah, my name is Dr. Gabriel Ayeni, leaning for the WHO. I'm a public health expert with over 10 years experience in emergency preparedness and response. And we are glad to be part of this occasion. Thank you.
So some minutes into time already, so we'll take some questions. We have 5 panelists, and the theme is infectious and non-infectious disease outbreak prevention, detection, and response for sustainable universal health coverage. The modus operandi would be the panelists will speak for 5 minutes to 7 minutes. If you can spare a few minutes for questions later, so that you have 3 minutes at the end. And then we'll take questions from the audience, and they will respond to the questions. We'll hope to have 1 hour to cover the session, and hope we'll be into time. So I will start with the first speaker, and I would like, because we don't want the technology to fail us, so we'll take from Africa CDC, the first speaker will be Dr. Kabede Enyu. And Dr. Ebedi, if you can hear us.
Yes, I can hear you.
Right, so we know that we've had COVID in the past, and COVID had come with a lot of disturbance and disruption of the health system, particularly ensuring provision of services, both preventive and services and curative services. Would you like to discuss with us how effective surveillance systems and early detection strategies for infectious diseases in Africa, if you could share your insight on leveraging data and technology that are available so that we can enhance disease monitoring for timely detection so that we can ensure universal health coverage. Dr. Enyu, please.
So I have few slides. Can I share slides?
Yes, please proceed.
Okay, thank you. Thank you. I will not take much time. So I have very few slides. I hope I will be allowed to share. Can you see my slides? Hello, can you see my slides?
Yes, we can see your slides. Please proceed.
Excellent, excellent. So I'll take a few minutes of your time and share, what we are trying to do at Africa CDC in terms of, strengthening surveillance and early detection of infectious diseases. And from background information, we face really high burden of infectious diseases and frequent outbreaks. The continent responds nearly on average of 100 outbreaks every year, which some of which are really very, very severe. And in the last decade, zoonotic disease as a cause of outbreak have increased by 63%. And also what climate change is bringing, like increasing the spread of diseases to the highland areas of Africa, especially vector-borne diseases, cyclones leading into cholera outbreaks, and so on. So our surveillance system should address also climate exacerbated disease as well. So what the continent is doing is we have adopted IDSR, which is a WHO guideline since 1998. However, this is a very slow process because this is indicator-based survey. So we need to focus also, in addition to indicator-based survey, the event-based surveillance, which is really very, very important. So there are a number of limitations on the current surveillance program, where there is weak event-based surveillance, and that's leading into late detection. And then we have problems of data sharing across member states, inadequate training, trained workforce, and so on. So we need to change really these systems if you want to have a strong early warning surveillance system. So this is a EBS capacity in Africa. Most countries, at least 34, they have some sort of event-based surveillance program going on. However, when we assess with a scorecard, which is very, very objective, there is no any countries that have optimal capacity for event-based surveillance, which is an early warning surveillance system. So a lot of work is required to really change this problem. So as Africa CDC, we have been working with member states. We have reached around 22 member states in supporting them to implement event-based surveillance. And we have a number of documents. As you see here, we have a training program. We do have, the event-based surveillance framework, which we launched it in 2023. We do have also, One Health framework for national public health institutions. And this is very, very important to really strengthen our surveillance system. And we have also an electronic tool which captures all events as they come in, and some countries have adopted it, and we are working for this electronic system to be applied to most countries. Using this electronic system, in the last 3 years, we were able to capture 616 events, out of which 500 were human events, 80 animal, and 36 were environmental. And this is telling us that we need to do more on animal and environmental sector in One Health approach to really make sure that our surveillance system is very sensitive, and we are also addressing other sectors while we conduct our surveillance program. And these are some capacity building activities, training programs that Africa CDC is leading. And then we have also, launched a health information exchange program, which is fostering, the sharing of data by member states. And this standard and guideline has been adopted, validated by 47 African Union member states. We feel that, this is very, very important to bring continental data together so that we have an early warning surveillance data coming in real time, and that's available for decision makers to make immediate decision-making process. So collecting surveillance data from facility alone is not enough. So we need to use other additional information like weather forecasting, population mobility, pathogen genomics, and other big data. And artificial intelligence is very, very important, to improve our surveillance program. And these are some of the examples where we can predict the weather condition, and then we know, what's next. For example, because of tropical cyclones, we had a significant increase in number of cholera in Malawi and Mozambique. And then because of severe drought in Ethiopia and Somalia, there has been an associated diseases like cholera. So if we know, what's coming in terms of weather forecasting, and then we can improve our surveillance program to predict, what will be next. And we know also, the Rift Valley fever happens after a series of flooding. So if we know that, there is a heavy rain, and then we can anticipate that, there will be a rise in terms of Rift Valley fever. So as you know, disease spillover from wild animals to domestic and then humans. At times, disease can also be transmitted directly from wild animals to humans because of the encroachment of the human population into unusual environments that they have never been residing before. So if we want to really, improve our surveillance program, we have to look into what's happening in domestic animals, what's happening in wild animals. And then if we know and if we can predict that one, we can significantly reduce, the human cases. This is, for example, a model where if you have, a strong surveillance system in wildlife and in domestic animals, as you see in the red curve there, we can significantly reduce, the human problems. So artificial intelligence, as you know, is very, very important. It allows us to use data, not only, health data, but physical world like environment, insect vector. We can look into, social media, forums, and blogs, and so on. All of that can be used as a source of data for our surveillance program. And then artificial intelligence can improve our analytics, and then it can also help us, to really do modeling and simulation exercise. So this is a growing field, and I think we need to implement it more and more so that, we can improve our surveillance program. So pathogen genomics is another area which is very, very important. So in the last 3 years, Africa CDC and other partners, we have been leading this effort. And today, more than 39 countries do have sequencing capacity. And they need to expand, to do more sequencing for all other pathogens. Currently, it's mainly focused on SARS-CoV-2. So we have seen that, how powerful this sequencing technology is, and we need to apply to understand, the circulating variant. We need to apply, pathogen genomics for transmissibility and so on, for manufacturing of vaccines, diagnostics. So this is a growing field, and we need to incorporate, pathogen genomics into our surveillance program. And in conclusion, I think we need to strengthen, our early warning surveillance system as part of the pandemic prevention, preparedness, and response. To do that, we need to continue with the usual indicator-based surveys. These are, daily, weekly, and monthly reportable diseases. And then we have to embark on implementation of event-based surveillance, which collects information from not only from the health sector, but from other sources. And we need to use other data sources, as I mentioned, pathogen genomics, artificial intelligence, weather forecasting, and so on. So that's what I wanted to share. Sorry to rush you because the time given was short. Thank you again for inviting me. We as Africa CDC, we would like to collaborate with all stakeholders to really, make early warning surveillance and response system in Africa very, very strong. Thank you very much.
Thank you very much, Africa CDC, and thank you very much, Dr. Enyu, for that presentation. I'm gonna time now, 5 minutes, that will be the first bell, and then 7 minutes that you will stop to submit. So please use your time wisely. Thank you very much. Now I welcome Dr. Slim. And here, Dr. Slim would like you to discuss the role of disease prevention and health promotion in achieving sustainable universal health coverage. Give us practical examples from Zanzibar and elsewhere as you venture through this. Thank you and welcome.
Thank you, Professor, for giving me this opportunity, and thank you, everybody on the floor. Honestly, we know that topographically, Africa is very conducive for infectious disease. So we have such environment that allow the disease to perpetuate. So one of the mainstay scientifically proven to able to eradicate the infectious disease from the face of the earth is vaccine. Without vaccine, we will continue to suffer. So we know there's malaria, there's measles, there's polio, and if we leave any part of the community unvaccinated, we just expose them to a great danger. But also changing in our lifestyle, and everything has changed on how we behave towards food. We now, as African, has a lot of non-communicable disease. So now Africa become an epicenter of comorbidity, which is associated with mortality and morbidity in relation to both disease. So if you're not dying for infectious disease, you will either get a non-communicable disease. But let's be fair, it's only over 70% of this disease of both origin are modifiable. We've spoken about vaccine, and obviously our behavioral will probably be the proxy indicator that determine the outcome of each and every one of us life. So if you are engaging in poaching, if you are engaging in behavioral, that will definitely cascade you to the outcome of interest. So it's important that we understand each and every one of these diseases do originate from the community. So it's important we emphasize on community ownership. The community, they're the one that got the problem. They need to own it. How are we going to get there? We're going to get there by educating them. We educate them by emphasizing the knowledge so that we improve their knowledge and attitude toward the disease, be it HIV, be it tuberculosis, be it anything. But if you give the community back their own problem, at least by giving them the knowledge, now you tell them how to be aware of it. If you consider any outbreak, it will start from the community. If the community are well aware of the problem, they will probably be the index case that will provide information to the institution on the nature of the situation. But we also need to look at the health system lenses. Country with very weak health system has suffered more in COVID compared to those who has very strong health system. So looking at the pillar of the health system and see where are we weak. So if you look at, say, for example, in the context of Zanzibar, our health system is thriving, yeah? And having COVID did not help us because we are investing in tourism, but at the same time, we were in the pace of just about to pick up in terms of strengthening our health system. So when COVID came, it was more of a double burden from healthcare perspective, but also economic perspective. So in Zanzibar, for example, we focus on COVID. All the resources went into COVID, and all of a sudden, we begin to see abruptly case of measles. But it was evident on other areas of sub-Saharan Africa. So it shows the weakness that we left behind, major component of preventing our children and other population. So we took an opportunity in us where we had a polio that came in the region of Malawi, and we were giving some resources to vaccinate our people. So having measles on the mainstay, apparently there was no a policy in the book that allowed us to kind of mix vaccine. But we did not wait for the policy to come along. What we did, we look at the science, what explained to science, and we realized that 16 of our children within the first quarter were lost. And those deaths were contributed by those children who either underdosed or probably half dosed, but also other area that drive them was undernourished. So we made a decision based on biological plausibility mechanism to integrate the vaccine. And we integrate measles and polio, but also we also try to give our children a dose of vitamin A as a precursor for the immune system to fight for infection. And we did that. There was a lot of repercussion on why we do what we do when there is no book. I say we can't continue waiting for policy, which will develop for 4 years when the children are dying. Clearly, poliovirus doesn't share a receptor with measles vaccine. So there is no competition in relation to legal binding, if anyone here get to understand that. So we allow that to go, and then all of a sudden, Zanzibar has become a place where measles is no longer public threat. So we did not wait for the policy and things to be done. We get gathered by science, and that science now maybe will open window for those opportunities for other countries to adopt our modality. So what I'm trying to say here is nice to be able to understand the concept. The concept is to give community ownership, whatever it is you do, because it begins with the behavioral, right? If be it malaria, be it diabetes, it starts with the community. If the community are more educated, at least giving knowledge, their attitude toward their health will change. But also we look at the health system lenses, and then we have to invest in vaccine. But the most important is to make sure we go to the person who require the service. In Zanzibar, at the moment, we have our CHW who go house to houses to ensure we understand individual health status. And if they are pregnant, we allow them to come to work to the facility to seek care as early so that we can understand their problem, so that we can intervene. And that will lead to the reduction of the challenge associated with maternal and reproductive health. And obviously, we really have to ensure health equity, right? The meaning of universal health coverage is to make sure everybody who need the service get the service, but not everybody is in the same paradigm of economy. We have people in Zanzibar who is pregnant woman encouraged to go to the health facility with 2,000 shillings in her pocket. She decide whether to take a bus to the clinic or to get a loaf of bread. So we can't get the woman to the facility. So we will have to have a mechanism to reach out for them. So we need to go to where the community are and provide them. Combining doing this, so I believe it will help us to prevent, respond, and mitigate disease of both origins, be it infectious or non-infectious disease. Thank you very much.
Thank you very much. A round of applause. Thank you very much for sticking to time. Now we will call from Red Cross. When we speak about disease detection, control, I think we cannot avoid to speak about effective partnership. Would you kindly look into that and just let us know from your lens, from your perspective, how effective partnership, bilaterals, multilaterals, but also community engagement, as we hear as a continuation from Dr. Slim. Please.
Thank you. Once again, good morning, and thank you for having me to speak about the Red Cross experience in infectious disease outbreaks. And I'm here on behalf of my Secretary General, who had to be abroad for an equally important matter. Just a snapshot about the Red Cross in Tanzania. We were established by Act of Parliament number 71 in 1962 as an immediate responder to Sorry, is that to me? Okay. As a first responder, as an auxiliary to the government, when there are outbreaks and disaster occurrences, and in response during times of war, and during times of peace, we're supposed to engage in public health and disaster preparedness and disaster response where it is necessary. So with the current interconnected community and the rapid spread of diseases across borders, it is absolutely necessary for us to act together regionally and again locally for the safety of our community members. And the Red Cross has been working with the Ministry of Health of Tanzania, the Prime Minister's Office, the Health Ministry of Zanzibar, local government authorities, United Nations agencies, the International Federation, Africa CDC, the USAID, CDC here in Tanzania, the likes of Coca-Cola Foundation, banks, telecommunication companies. I'm just trying to show how we've really tried to use the whole network to maximize the impact of the responses that we put in place. Our advantage is that we have 31 regional branches, meaning a branch / an office in every region in Tanzania, mainland and Zanzibar. We have 90,000 members and over 300,000 volunteers at the ready across the country to work with whatever authorities and organizations that are out there. And specifically, I'll go to the Marburg virus disease outbreak that was announced in the middle of March this year, where upon receiving the Ministry of Health announcement of the occurrence of the disease, we did the following immediately, which I think are worth talking about. So we reached out immediately to the regional medical officer of Kagera to come up with the magnitude of the problem, to identify the gaps that were there, the short-term needs and the long-term needs. We launched an emergency appeal to our mother agency, which is the International Federation of the Red Cross and Red Crescent Societies, for 4 additional ambulances, supplies of body bags, protective gear for safe and dignified burials, items for IPC, technical and financial support for training community health workers along with volunteers on community-based surveillance, something that we call psychosocial first aid, behavior change communication, and IPC. And also for transport allowances for any volunteers and community health workers that would be trained to work with us in house-to-house awareness promotion, referral, and what we call the gathering of rumors from the community to influence our messages better. We appealed to UNICEF to support wash and nutrition interventions. We appealed to Africa CDC so that the same volunteers that that we use for promoting COVID vaccine uptake would also be utilized to facilitate the implementation of RCC for the Marburg virus disease outbreak. We also appealed to our neighbors, Uganda Red Cross, because they had already experienced, I think, up to 9 outbreaks of Ebola virus disease. So they were in better shape to work with us in response to MVD, which in a lot of ways is similar to EVD. And the results were awesome because first of all, we were able to receive almost everything that we requested for. Although there were hiccups in getting consignments of what we asked for at the border between Uganda and Tanzania. For example, it took 6 weeks for the body bags, IPC material, and all the other consignments to be allowed into the country. However, the Kagera RHMT, together with central government, were able to work with us and the other partners to have a very well centrally coordinated response. So the key thing is that the International Federation, along with us and other partners, were able to centrally pull in all our resources. There was what I can call a very good accountability system where partners had to pledge what they would pull into the common pool, and every day there would be a check on who hadn't brought what they pledged to bring to the table. There was no overlapping of resources, of resource procurements. There was no, there was a much improved coordination of how to utilize vehicles so that every targeted area could be reached easily with consignments, with messages, with follow-up and support. There was a very good rumor tracking system to modify, to review, to improve messaging and support. What else have I left out? Essentially, that's the second bell. So in conclusion, the necessity of global collaboration and multilateral efforts to address infectious disease outbreaks cannot be overstated. And Tanzania Red Cross Society, in partnership with the government, international organizations, public-private collaborations, and regional initiatives, will continue working tirelessly to ensure that our nation is prepared to prevent, detect, and respond to outbreaks effectively. We know that together we're heading towards achieving sustainable universal health coverage goals and ensuring that healthcare is accessible and affordable for all. Let us continue to work hand in hand to build a healthier, safer, and more resilient world.
Thank you very much. Thank you very much. A round of applause for that engaging and actual experience from the field as a bridge from international forum from Red Cross. When we had Marburg, we're almost getting out of PPEs, and we were worried. And so we reached out to WHO, who said, WR said, you know, WR from Uganda is coming at the border. Why don't we organize to get the things from Uganda to the border and from the border to Kagera? And everyone else, including TMDA and all the regulatory functions, were there to receive and to ensure that there's safety and there's adherence to policies and all the protocols. So that's the power of networking. That's the power of effective partnership. And thanks very much for enlightening that. I hope that's a very good bridge to WHO now, please. We will not speak about partnership because that's your role as WHO, but we'll speak about other function in terms of capacity building, capacity in terms of the systems, capacity in terms of human resource for health and other support functions to build the capacity to detect on time, to control the disease, also to survive after, during the outbreaks, but also after, ensuring availability of services is continuing. Karibu sana.
Thank you very much, Chair. It's a pleasure to be here today, and I'm so glad to represent my country representative. it's good to start by saying that we are not starting from the scratch. A lot has been done and a lot of progress has been made. Recently, the country conducted a joint external evaluation, and we could see a quantum improvement from a score of 48 to around 60, which showed that the country has made significant progress, at least in the last 5 to 6 years. And building on that, there are three essential elements that we need to focus on more to see how we can continue to build capacity, not only to respond to emergency, but also to prepare adequately for every emergency. And I will put these three elements as governance, systems, and financing. And as we could see during the Marburg response, which is one critical examples that we have of late for the good performance that the country achieved, we could see the importance of commitment of political leader to capacity building for effective preparedness and response. And also around the governance element is what we call multi-sectoral collaboration, which is also very important and which was also well demonstrated during the Marburg response. And the last but not the least on governance is how do we strengthen legislations and policies. These three components of governance are quite important for us to achieve capacity building in every sector of health preparedness and response. If we can strengthen our commitment as political leaders and also strengthen our multi-sectoral collaboration, and of course, act promptly to review and strengthen existing and probably introduce new laws that we ensure capacity are continuously built across spectrum of preparedness and response, then we can say that we are on the way to achieving better results when another evaluation is done in the next 5 to 6 years. And also looking at our systems, we could say that Tanzania is one of the countries in the African region that has made, of course, giant lead progress in the area of health system building, especially in the area of preparedness and response. When you look at plans, when you look at the Public Health Operations Center, when we look at the RRTs, we can say that Tanzania indeed has actually made progress. But taking, for example, the Public Health Emergency Operations Centers, which we have at the national level and also in 6 regions. What is stopping us from moving to having the same thing replicated in all the regions in the country? Because we have seen the importance of having a Public Health Emergency Operations Center in building capacity, and not only building capacity, also ensuring capabilities for effective preparedness and response. We have agreed that we have made good progress by having these public health EOCs in the country, but there is a need for us to move a step further to have it in, if not all the regions, at least strategic regions, within shortest possible times, for us to build capacity in a sustainable manner and also have the capability for response. Yes, we have the RRTs in the country. Recently, in many regions, we have the RRT, if not all the regions. And of course, recently, WHO collaborated with the Ministry of Health to train 132 responders to join the RRT force in the country that could support the country. And it is high time also we move further to also have more people that are capacitated, just like we have capacitated 132. 132 cannot spread of Tanzania. So there is a need to do same for more health workforce in the country. Also, maybe because of time, also, I would like to quickly move to the financing. This is one critical area that if you are making good progress in other areas and you are not making progress, or you don't have a good plan for sustainable financing, definitely it will continue to slow us down. So it is high time for country to prioritize. While the country has, of course, good intention when it comes to response, we have to do a lot more in the area of preparedness, not only for infectious disease, also for non-infectious diseases, because based on record with WHO, as we are having occurrences of infectious diseases across countries, so also we are having surge in non-infectious diseases and also other hazards, major hazards in African countries. So it is high time also, either by legislations or by whatsoever means we could, to have a system that we can refer to as being sustainable to support capacity building for preparedness and response in the country. If we can do all these things, I think we can effectively make good progress when it comes to response. Thank you very much.
Thank you. Thank you very much, Dr. Gabriel Ayeni, for highlighting the importance of finance and in preparedness all through across the spectrum, before, during, and after. Now we'll switch gears and talk a little bit about non-communicable diseases. I welcome Professor Rains to discuss on non-communicable diseases, if you will. I'll give you 5 minutes, first bell, and then the second bell.
Yes. I have to do it here. Okay, thank you. Thank you very much, Prof. Tumaini, for having me here. And it's really coming back among friends. May I have the next slide, please, or can I do that? Yeah. So I really would like to emphasize that we are currently facing a double burden. The double burden of infectious and non-infectious diseases, non-communicable diseases. And when we just have a look here on this map, you can easily appreciate that Sub-Sahara Africa is the hot topic in the world related to non-communicable diseases. This is one of the really major challenges we are facing in this region. Next slide, please. When we are talking about non-communicable diseases, we are talking about cardiovascular, respiratory, cancer, mental health, and diabetes. And there are lots of relationships between infectious and non-infectious diseases. Many viruses are drivers for the development of NZDs. Many viruses and infections are drivers for the exacerbation of non-communicable diseases. And patients with non-communicable diseases are more prone, are more susceptible for the development of infectious diseases. We have seen that with COVID recently. Patients suffering from NZDs are at higher risk for more severe COVID, for more and increased mortality. Next slide. So the really burden in terms of death rates, for instance, in adults is Africa, the low-income countries in this regard. Next slide, please. I have to be a little bit more faster because of the time. Next slide. So the first important question is, what is the reason for this dramatic increase of non-communicable diseases in Sub-Sahara Africa? And here I would like to draw your attention to the most recent NZDI poverty report here from Tanzania, published August 2020. And on the next slide, you see here the key statement. With the common risk factors, we can only explain a little bit of the burden of the diseases, meaning that 80% of the burden of non-communicable diseases in this region remains unexplained. And this is a major challenge for us. We need to identify, next slide please, the risk factors for the development of these diseases. And number one, in our opinion, is urbanization, industrialization, and Western diet. And in industrialization and urbanization, next slide, are closely related to climate change. And I am very pleased that Dr. Kebede from the African CDC already introduced the importance of climate change as a major driver for the development of these diseases just recently. And on the next slide, I would like to show you here, I take the opportunity now for the first time, real data on the situation in Tanzania, which we put together with our team in the Kilimanjaro region at KCMC. And we compared, and next slide, please, and we compared the development of NZDs in the urban region, in the city region of Moshi, and compared it to the urban urban district. And on the next slide, you see what happened just over the last 10 years in that region. A dramatic increase in yellow in the city region in any of these non-communicable diseases, much more than happening in the rural region. And this is, next slide, closely related to the increase of rainfall and rainy days in this region. So there is an immediate association to climate change, and on the next slide to air pollution. PM 2.5 levels, ozone levels, and NO2 levels increased at the same time. So this at least shows us there is the association between non-communicable disease, climate change, and air pollution. And this is a major challenge for all of us if we talk about prevention. Next slide, please. And all of this with climate change is related to starvation. And I would like to draw your attention, next slide, please, to the poverty report here in Tanzania, the data from 2022, still in this country, in our country, and I'm a resident of Tanzania, so I can say in our country. 30% of the children under the age of 5 are still stunted. Although we have improved the situation, we still remain to work on this important aspect. And finally, we have to draw our attention to the first 1,000 days in life. I think this is very important. This is the window of opportunity where most of the things happened, and this is related to the Barker hypothesis, the fetal origin of adult diseases. So the focus on the first 1,000 days pregnancy and the first 2 years in life is very, very important. And this is related what you said from Zanzibar, vaccination programs, education, training programs together with WHO. We are now starting close collaboration with WHO on these topics, and I'm very pleased about this action. Finally, last slide, please. You can go on to the last slide, please, so that I can go on. Next slide. Next one. Next one. Yeah. So when we are coming to primary care settings, here again is a map from your own publication indicating the availability, and I just take this as an example, of asthma services at district and regional level hospitals in Tanzania. And you see the map is red, not green, it's red. No screening, no treatment is really available on the primary care level. So we all need to develop programs in order to bring the knowledge and bring the treatments and bring the prevention to the entire population of Tanzania. So the last slide, please. I think we have here opportunities and challenges. The impact of climate change on biodiversity, on the disease, the identification of novel risk factors. Only if we know the novel risk factors, we can implement prevention strategies. We need environmental intervention, the early origin of the disease, we need screening in primary care, and we need more private-public partnerships in order to tackle this problem. Thank you very much for your attention.
So can we give another round of applause to all the presenters? They have been wonderful, isn't it? So, especially with timekeeping. Now we will take a few questions before we close. We are running short of time. We have 5 minutes. I'll take a few questions. I have two this side and this side. Okay, so half a minute, a question right to the point. Yes, Karibu.
Thank you so much. Mine is not maybe a question, Martin, medical doctor. It was a very good presentation. My point is that we are speaking of infectious and non-infectious disease, and now we are encountering the emerging and re-emerging infectious disease, which are of pandemic impact or potential. My concern is that we have been observing that most of these emerging infectious diseases have been zoonotic causes. And it has been from the environment, and it comes to animal, then to the human beings. So it has already been observed that animal have been dealing with their specialists and veterinary people, while as medical doctors and all health personnel have been dealing with people, but environment have been dealing with the environment in general and also maybe with other vectors. My call is that can we go and break this silo, that we bring together all these disciplines from the animals, environment, and human, so that we have an approach that will be One Health involving all these stakeholders. Thank you.
One Health desk at the Prime Minister's office. For sure, there should be room for improvement to enhance the desk. Thank you.
Yes, I've two things. One thing is on the map, the available. We are not really super specialized. I think the availability of asthma services is available. Even you see on the northern zone, we have Mount Meru, we have KSMC, which on the map was North Services. But I think as a chief medical officer, you can respond onto that. But I think the care is there, but even in our standard treatment guideline, there is a guideline for asthma services. And the second thing is we needed to improve funding for non-communicable disease. I understand the HIV, malarias, and other infectious disease, but there is a surge of non-communicable disease. As we are the drive for funding for infectious, there is a need to treat non-communicable as epidemics, which need a lot of resources in order to curb them. Thank you very much.
Thank you. There's a question at the, yes, please. I'll take a lady.
Thank you, and thank you all for very lovely presentations this morning. My name is Maria. Just picking up on some of the things that were spoken across the panelists, perhaps something that's becoming more evident is that there isn't enough funding, right? We can't continue to depend on government alone, on development partners alone. There is definitely a need for the private sector. So my question here is, what role do you see that the private sector could play to extend services to at the community level? I think especially have you seen or can you speak to successful business models that private sector have deployed to extend healthcare at the community level using community health workers? I understand that recently the government of Tanzania passed a policy that did recognize that CHWs should be compensated, but I don't believe that they have formally hired CHWs. Perhaps you can correct me if I'm wrong, but I'm more keen to understand if there are business models or if there is a role for
Thank you. Thank you. So Rains, maybe you can take that. There was a question at here, right? Yes. So the two were comments. So one question and the second question, yeah?
Thank you. Excellent questions. I think sector as that reflect what role private sector can play in here many people to the private sector as their first port of entry. So what role play in these diseases? Thank you.
Right. The last one I'll take from Mary Rose. I'll give, that will be the last question.
Thank you very much, moderator. You've mentioned my name, so I really wanted to congratulate all the speakers. And my question is very simple, goes to the last speaker on NCD. I really wanted to learn if there's any country in the low middle income who have done programs that focus on climate change and NCD, and what are the key core activities which they do. Thank you.
Right, so thank you very much. In the interest of time, I think we will have to stop there. This discussion was getting nicer, but so the two questions would be private sector role and then climate change and non-communicable diseases. I'll ask Professor Renz to start, and then we can give one more person. Yeah.
Yeah, thank you very much. I think these are really great questions. Regarding to the private sector, I think, in my opinion, look, coming from Germany, from the outside, look, Tanzania of huge opportunities for investments, and see, for instance, the production of vaccines in the country, the production of medication in the country, not buy them from India and China. Nothing against India and China, but it would be better to produce the main medication in the country, not only made for Tanzania, but also for Eastern Africa and beyond. So there is opportunities for investment, and I think one needs maybe to encourage also the government, the economic ministry, the finance ministry, to reach out internationally and open the doors for these investments here in the country. Related to your question with programs, unfortunately, I think this is really the lack of programs. I don't see any country in sub-Saharan Africa who can use as a role model in this regard. But I see again huge opportunities for Tanzania to step up and to take the lead in this regard, because you have the infrastructure, you have NIMRI as a fantastic public organization. You have fantastic researchers and scientists at universities here in the country. So just bring them all together and we move forward.
Thank you very much, Professor Renz, for responses. I think we don't have time, and we'll have to encroach. We're encroaching to the other presentation and perhaps a tea break. I'd like to take this opportunity to thank my panelists. They've done a wonderful job. A few summary, if I may. One, it's important. Surveillance is key, and we have to stop being complacent from routine surveillance, but also we need to use AI in prediction of diseases and get ready. Leveraging resources, particularly in integration of our services and community engagement, but also to ensure sustainable financing. The last was an intersection between infectious and non-infectious diseases, particularly the role of viruses in inflammation, into cancers, but also inflammation in exacerbation of diseases, but the role also of intrauterine insults that may result to long-term non-communicable diseases. These, I think, are the main take for today, and I would like you all to thank you for your active participation, and please join me in giving them a round of applause again.